The final chapter, family-centered care in palliative care. What is palliative care? Palliative care is care that helps people live their life as fully and as comfortably as possible when living with a life-limiting or terminal illness. PAL care is holistic in approach. It identifies and treats symptoms which may be physical, emotional, spiritual, or social. Because palliative care is based on individuals' needs, the services offered will differ but may include relief of pain and other symptoms such as vomiting and shortness of breath, resources such as equipment needed to aid care at home, assistance for families to come together to talk about sensitive issues. They can include links to other services such as home help and financial support, support for people to meet cultural obligations. It could include support for emotional, social, or spiritual concerns, counselling and grief support, referrals to respite services. Palliative care is a family-centered model of care, meaning that family and carers can receive practical and emotional support. Palliative care combines science with compassion by adjusting treatments to the unique needs of the individual patient and by taking into account the patient's and family's spiritual and cultural context, interests, roles, and strengths. Trajectories of death. In the top left-hand corner, you can see sudden death, where we die unexpectedly, such as a motor vehicle accident, myocardial infarction, or a stroke. Only about 10 to 15% of all deaths follow this trajectory. On the top right, you can see terminal illness trajectory, where the patient has a long-term disease trajectory, followed by a shorter phase of sharp decline. Many patients can function reasonably well until the final decline. Examples of this would include cancer and in cases of late diagnosis of chronic illnesses such as advanced lung disease. Organ failure is a fluctuating trajectory of death and can be seen in the bottom left, where patients has a steady decline in physical functioning with severe symptom crisis. Failure of heart, kidneys, liver, brain is a common cause of death. Often patients are hospitalized with exacerbations and each time decreases their functional baseline until final death. And finally, fragility, which is a slow, steady decline, with death commonly a result of sepsis, renal failure, or progression of another disease. This curve is usually associated with dementia or extreme age or post-stroke patients. For children, the three most common trajectories near the end of life are sudden death from trauma, fluctuating decline, such as worsening heart failure, and constant medical fragility, as with neurological impairments. The phases of palliative care. As nurses, we are often there during the lead up and at the time of passing. We are the hand holders, the tissue suppliers, the constant familiar face, and we listen with the ear of our heart. Palliative care is not exclusive to older adults. However, thanks to modern medicine, this is often the case. But death can occur across the lifespan. Personally, I have cared for mourning parents saying goodbye to their stillborn son, helped parents of children managing a life-limiting illness, supported families of teenagers and adults who too have passed from sudden or other slowly disappearing. We are blessed with the opportunity to touch and be touched. When it comes to family-centered palliative care, there are many resources that are available to help guide practice, empower you to support the family, and in turn support the patient. From the image you can see how the family is the center, then surrounding it is all who work with them to support and care for them together as they face grief and loss of a loved one. This one is specific to pediatric patients with a life-limiting disease. As many palliative patients choose to die at home, often the role of caregiver is given to the family. Common reported challenges include emotionally coming to terms with the disease progress towards end of life, managing caregiving, dealing with uncertainty, responding to symptom-related suffering. Palliative care aims to address these issues and provide psycho-educational and supportive interventions such as appropriate referrals. Family meetings are commonly participated in palliative care at time of admission to inpatient services and within the community. This is a structured gathering of multidisciplinary caregivers, family members, and the patient. Together they discuss treatment, management plans, formulate goals, clearly define roles and responsibilities. Research has shown that family meetings increase family satisfaction, feelings of empowerment, and are associated with a shorter, less complicated grief period. There are restrictions to family meetings, largely related to the family structure, ongoing conflicts, lack of communication, and geographical separation. Here are some references and resources that I used to put this presentation together. Thank you.